sincerely, and Galit knows that, for me to introduce our first keynote speaker today, Dr. Galit Kleiner. I'm sure you've had an opportunity to read the bios of all the speakers displayed out in the hall, so by now you know that Dr. Kleiner Fisman is a neurologist who specializes in movement disorders, and she's therefore very well qualified to speak to you today about Parkinson's, more than a movement disorder. But I would like to take a few minutes to share with you some aspects about her that you don't know. About a year ago, Galit was asked to be a resource and answer questions for patients and their care partners who were attending a self-management program. The original 30-minute session ended up being 2 hours in length, as the participants had so many questions and so many aspects of their journey with Parkinson's. Following that session, many of the participants requested to be Galit's patient because they felt that they weren't getting enough information from their own doctors, and they felt very comfortable talking to her. They saw that she was someone who would listen to their concerns and to address the things that really mattered to them. Knowing that she couldn't possibly take on the world and the entire Parkinson's population, instead of just letting it go, Galit decided to request funding for a research project, the objective of which is to develop patient-oriented electronic education materials that can be shared via DVD and on a webinar that will address common but frequently unanswered questions posed by patients, care partners, and family members. Useful information for allied healthcare professionals caring for advanced Parkinson's patients in long-term care facilities will also be addressed. The most important part of all of this is that the information will be given in straightforward and easy to understand terms. The first focus group to help develop this web-based educational presentation on Parkinson's was held just on Wednesday of this past week, and I checked with Galit this morning, and there is indeed more room for you to attend more focus groups, and I've got some information about that today. This tool will empower patients and their families on how to best manage and optimize their quality of life, as Galit believes knowledge is power. This is just one example of many research projects Galit is involved in, while managing their very busy patient practices at both Toronto Western Hospital and Baycrest Centre. Oh, I forgot. She's also the mother of 2 precocious, gregarious, you didn't say obnoxious, did you? No, that wasn't a word. No. Lovely children. They keep her hopping when you don't. Galit, in my opinion, is the epitome of the saying, if you want a job done, and you want it done well, give it to the busiest person you know. Please join me in giving a warm welcome to Dr. Galit Kleiner.
Inspires me most are the conversations I have every day with people living with Parkinson's and the challenges they face and the grace that they have to live with those challenges and find incredibly creative ways of addressing them. So while Parkinson's indeed poses challenges, I believe that having accurate information is setting the stage for empowerment and for finding one's individual path as to how to live well. So I hope that today I'll be able to offer you some information that will be useful to you. So when I was asked to address this group today, I thought, well, what would be of greatest interest to a wide range of audience? And I thought about the conversations I have every day with people in my office. And of course we talk about movement-related symptoms of Parkinson's disease. Everybody knows what these are. But then I thought about what we really spend our time talking about and why I'm perpetually late, and that's related to the non-movement symptoms associated with Parkinson's disease. People are often reluctant to discuss these with me because often they think, well, she's a Parkinson's doctor. What does she know about problems with my bladder, and what does she know about the fact that I feel sometimes confused and things like that. And in fact, because these non-movement symptoms are seemingly unrelated and often can be subtle, they tend to either be dismissed by other healthcare professionals, or they are misdiagnosed. People have good intentions and they pursue all sorts of investigations and even treatments that are often inappropriate. So, what is my goal today? My goal is first to describe a very wide range of non-movement symptoms and discuss how common they actually are, and then talk a little bit about how these can impact quality of life. But what's really important for you when I give you this whole survey, this huge list of symptoms, is not to get intimidated and say, oh my gosh, this is even worse than I thought. That's not the intention. It's just to make you aware that these exist. There is potential for treatment, but you need to know what these are before you know where to seek help. So it's also important not to compare yourself to your neighbor. Everybody experiences Parkinson's differently. And so while there are commonalities, there's also a lot of variations. So I just thought I'd give you a little bit of a historical perspective. And this is the cover of the original treatise describing Parkinson's disease by Dr. James Parkinson in 1817. And in it, he describes the common symptoms of Parkinson's, including tremors and stiffness and slowness. But he's also already been, at that time, aware of the fact that there are other non-movement related symptoms related to Parkinson's disease. And he writes, in this stage, the sleep becomes much disturbed. The bowel, which had all along been torpid, now in most cases demands stimulating medicines of considerable power. So, again, this is a review. Everybody knows the typical movement symptoms in Parkinson's disease, but I just wanted to review them to contrast non-movement symptoms. So we know some people have shaking, slowness, stiffness, difficulty walking, poor balance, their handwriting can become small, there's reduced arm swing, and their voice can become quiet, and often their posture becomes more bent. It's oftentimes these symptoms can improve with the replacement of dopamine, and that's sort of the standard medications that we use. In terms of non-movement symptoms, again, there are large number of these symptoms, and I'm going to break them up into some categories. The first one is mood and thinking, and for my research, because this is one of the research interests that I have, mood and thinking is a major problem for people and spans all sorts of different components. There's depression, there's lack of spontaneity or motivation, the term we use is apathy, there's low energy, anxiety, panic, hallucinations, and paranoia, which often are actually a side effect of medications. Poor impulse control, again, this is something called the dopamine dysregulation syndrome, which is related to medications. Memory loss, reduced ability to think clearly, reduced attention span, and sometimes confusion. People can have symptoms related to sensation, where they feel pain or numbness or tingling or burning. Some people experience a loss of the sense of smell and a change in their taste. And in terms of bowel and bladder, they can have urgency, increased frequency of urination at nighttime, and in extreme cases, there even may be incontinence. Other symptoms such as sexual dysfunction and GI symptoms, gastrointestinal symptoms, where people can have nausea. Again, this is often a manifestation of medication side effects and troubles having bowel movements. Constipation is a very big problem for people. Sleep can also be extremely problematic, but there are many different reasons why people have a problem falling asleep. We all know that if you have a lousy night's sleep, and I can tell you that for me last night, the next day you feel kind of lousy. And this is particularly true for people with Parkinson's disease because there's an entity called sleep benefit. There's some physiological something that happens that when you sleep well with Parkinson's, when you wake up in the morning, you, even before taking medication, feel great in terms of your symptoms of Parkinson's. That's not true for everyone, but for a lot of people that is true. And so sleep is really critical in order to feel well. Now, there are other symptoms that are sort of miscellaneous, and I couldn't put them in any particular category. Things such as changes in sweating, drop in blood pressure when standing up, and this could be both as a result of Parkinson's itself, as well as exacerbated by some of the medications used to treat Parkinson's. Flaky, oily skin, which is called seborrheic dermatitis, blurred or double vision, a feeling of the heart racing or shortness of breath, told you this large survey of all the possibilities. And the question you may have is, well, why do we get these non-movement symptoms, and why are they so difficult to treat? I guess the short answer is that many non-movement related symptoms are related to pathways in the brain that don't have anything to do with dopamine. We all think that Parkinson's is purely a loss of cells that make dopamine, but in fact it turns out that there are a lot of other cells that are also being lost that make other neurotransmitters in the brain that unfortunately we don't have treatment for. We really only treat Parkinson's disease with dopamine replacement, and so that's why you think, well, if I'm treating Parkinson's disease, how come these symptoms aren't improving if they're related to Parkinson's? Well, they're not related to dopamine. The other confusing aspect of things is that some of these symptoms, as I mentioned, are actually side effects of the dopamine-replacing medications. So it's extremely difficult sometimes to sort out which are symptoms of Parkinson's, which are side effects of medications. But this is what we have to do in order to be able to figure out how to treat them. So I just want to highlight to you a little bit how common, in fact, non-movement symptoms are. And I want you to know that this whole sort of endorsement of non-movement symptoms is really only kind of become in our consciousness in the last 10 years. Prior to that, people didn't really recognize the fact that non-movement symptoms were related to Parkinson's. And they would say, oh, it's not a Parkinson's problem, go see your family doctor. And people would be sent around to all kinds of different physicians, and nobody would really know what to make of these. So there's a very good clinic at University of Maryland, people that we collaborate with, that are really interested in the care of patients and in their quality of life, and they have a large patient population, and they did some very nice studies. A woman by the name of Lisa Shulman did a survey of some of the patients that come to her clinic, about 100 people, and she wanted to see how many of these people actually had non-movement symptoms, but she only asked them about 4 of the 30 symptoms I probably told you about. She asked them about anxiety, depression, fatigue and sleep disturbance, and sensory symptoms. And what she found, only 4 symptoms, and almost 90% of people endorse one of these 4 symptoms. And so I suspect that if she actually asked them about all the different non-movement symptoms, she'd find that everybody had, to some degree, some non-movement related symptoms associated with their Parkinson's disease. Now, the next question, which is a little embarrassing to the medical profession, I would say, is that she wanted to find out how well were doctors that were treating people with Parkinson's recognizing these non-movement symptoms. So we're not talking about GPs. Not even talking about neurologists. We're talking about movement disorder neurologists. And it would behoove us and the movement disorder neurologists to know what we're dealing with. So what she did was she asked the neurologists that saw their patients after a visit, what did they think? Did they have non-movement symptoms, specifically depression, anxiety, fatigue, or sleep problems? And she compared these to standardized tests that were performed on these same patients to look objectively for these symptoms. So these were the results. These highly trained movement disorder neurologists were only able to recognize depression 35% of the time in their patients that had depression. Anxiety, 42%. Fatigue, 25%. They did a little better on the sleep disturbance, 60%. So that's a bit disappointing, but it highlights how important this is and how not recognized it is, and it's not surprising then that the symptoms aren't really being addressed properly. So in large population-based Parkinson patient studies, they look to see what is the prevalence of these symptoms. And in general, I think this is probably relatively accurate. People had changes in sensation 40% of the time, thinking problems 40% of the time, depression 20 to 40%, hallucinations 10 to 30%, anxiety, fatigue. You can see these numbers here. So now, I'm going to switch gears a little bit, because what I've been talking about is non-movement symptoms that can happen all the time or randomly, but don't follow any particular pattern. I want to talk to you about another entity, which is even a little more confusing. It's called non-motor or non-movement fluctuations. So these are non-movement symptoms that come and go in a predictable fashion. But in order for me to elaborate a little bit more on that, because I think this is a fairly complicated concept to grasp, I'm going to tell you a little bit about movement fluctuations that come and go. And many of you may have already experienced this. We call these motor fluctuations. Motor fluctuations are, for example, when you take your medications, your Parkinson's symptoms improve. So your tremor gets better, your stiffness gets better, maybe your mobility is improved. And we refer to this as being on. On can also mean, it's not necessarily good stuff. You can also have involuntary movements, like dyskinesia, where you're moving excessively, and this is a side effect of being on. In terms of off, well, after a period of time, your medications may start to wear off, and your symptoms of Parkinson's may return. So you may have some freezing and walking, shaking, stiffness, slowness, and this is sort of a cyclical thing. And these fluctuations can often be described as being like on a roller coaster, on time and off time, sort of the ups and downs, and it may happen several times throughout the day as you're taking your medication. In the same way, non-movement symptoms can fluctuate accordingly. So usually, you don't get non-movement symptoms if you don't get, you don't get non-movement fluctuations if you don't get movement fluctuations. So usually, they parallel. And what happens is that these non-movement symptoms like depression or anxiety or any of the ones that I mentioned may come and go exactly the same way as the movement symptoms come and go. And it's really important to recognize this because these symptoms, even though they're the same as the other non-movement symptoms, are treated in a completely different way. Because in this case, you actually want to treat with the dopamine replacing medications. So let me just give you an example again about what I mean about non-motor fluctuations. An 82-year-old man has freezing when walking and shaking and stiffness when his levodopa wears off. Similarly, at the same time, when his levodopa is wearing off, he has predictable severe anxiety, confusion, and anger outbursts. Both the shaking, freezing, and stiffness and the anxiety and confusion are improved half an hour after taking a dose of levodopa. Here's another example. A 56-year-old man with foot shaking and difficulty walking when levodopa doses wear off. But predictably, he also gets incapacitating back pain at the same time. Shaking and difficulty walking and back pain resolve within half an hour of taking levodopa. Now this guy, this is an example of somebody that I've seen, he went to countless doctors to address this back pain. And he was even being considered for surgery, which is a disaster, because that's not the problem, it's not orthopedic. Clearly he's fluctuating. When we improved his motor fluctuations, his back pain resolved completely, and he didn't require any surgery. But it just highlights how incredibly important it is to recognize what is causing these symptoms. I realize I'm a little bit gender unequal because everybody here is a man. I should have changed it. So we'll say a 59-year-old woman with 8-year history of right hand shaking and stiffness. When she took a dose of levodopa, the disappearance of shaking and stiffness, but within 30 minutes after taking the levodopa, she also had predictably drenching sweats and restlessness, and it got better actually when the levodopa wore off. So not all non-movement symptoms are in the off period. Some of them are in the on period as well. So this was a study that was done, I think, 2002, when I was still a fellow with Dr. Lang. And we actually reviewed the study in our journal club. And it was a good study in that they had the right idea. They wanted to determine how many people with Parkinson's have non-movement symptoms that fluctuate, what are they, and what is the problem that they cause. So what they did is they looked at 50 people with Parkinson's, and they asked them to fill in a questionnaire relating to the Parkinson's experience. They had 54 questions about non-movement symptoms and whether they came and went predictably in response to levodopa. And this is the results. They found that there were many people that had non-motor fluctuations. As you can see, again, I only gave you a small list. There were 54 questions they asked about. And what they did was also informally ask people, well, how do you feel about these symptoms in terms of how much they bother you? And at least a third of the people reported that the fluctuating non-movement symptoms were even more disabling than the fluctuating movement symptoms. So, in fact, even though this was a really compelling study in that it showed and highlighted that there were a lot of people that had these problems were really problematic, the study was done fairly poorly, just methodologically, and I won't bore you with the details of that. And Dr. Lang at the time challenged me. He said, do it better. How would you do it better? And that has sort of embarked on, it's now been a 7-year project trying to do it better. And some of you have been involved in this effort. It started out actually when I finished fellowship. I went to Philadelphia and I had the privilege of working there in a dedicated Parkinson's clinic. And it was at a VA, a Veterans Administration this survey. It was completely, I couldn't understand what they were talking about. I don't know how patients could understand what they were talking about, because it just was not language that was easily interpretable. So it seemed to me that if we really wanted to capture the experience of the patient, what we had to do was ask the people living with Parkinson's, what are your symptoms? And when I say anxiety, what do you understand in terms of anxiety? And I wanted to make sure that what the words that I use are the same words that they use, and therefore we were actually able to capture the problems that people were having. And so we developed this questionnaire. We had many, many focus groups. We came up with all sorts of symptoms. We had something called nominal group technique, where we voted democratically on what the most important symptoms were, and eventually we came up with a list. You can see here, I think there were about 28 symptoms. I won't go into great detail about all of them, but as you can see, some of them are things we've already talked about. But we specifically used these words because what they understood was what I understood. And so now we're actually in the process of validating this questionnaire. And I would be delighted if any of you want to participate in that. And all that entails is essentially answering the questionnaire, and we're comparing it to other questionnaires that are out there that are not as good, but we want to show that we really are capturing the problems that we think we're capturing. So our goals are to determine how common these symptoms are in Parkinson's patients living in Ontario, how these symptoms affect their quality of life, in order to then come up with treatments that may be useful in improving these symptoms. So now I've given you this whole wide span of all the non-movement symptoms that possibly can occur that have been reported. And you're probably thinking, great, now doctors recognize that we have these symptoms, so that's validating, I guess, to some extent, but it's also kind of intimidating. Like, great, you told me about all this stuff, but then what can we do about it? And the point of today is not to overwhelm you or make you feel anxious. It's actually to empower you. In order to, I want you to recognize that these exist and that there is a lot that can be done. But the first step is recognition. So when, obviously, there isn't enough time today to talk about every single one of these symptoms and how we can treat them. But I asked Sandy, I said, can you help me focus on what people might want to hear about? And my experience, and it concurs with Sandy and Robert's experience in talking to many people living with Parkinson's, that there's a really big problem with depression. So I'll tell you a little bit about how do we treat depression. I'm going to sound like a broken record, but I'm going to say the first thing you have to do is make the correct diagnosis. And there are common misinterpretations. For example, people with Parkinson's often have a flat face, so it looks like they don't have a facial expression. We recognize that to be something that you see in people that are unhappy. So we interpret the masked face as a sign of depression. They may also not have the same motivation to do the things they previously enjoyed doing. That's apathy. But apathy is separate. It's not depression. Depression necessarily implies that you have to be sad, feel hopeless, have guilt. These are the diagnostic criteria. So while apathy is a problem, it's treated differently than depression. Sometimes people that have depression lack in energy and feel sluggish. But again, that's not necessarily being depressed if you have no energy or feeling sluggish. It has to be differentiated. And again, poor sleep is something that happens to people that are depressed, but it doesn't necessarily mean you're depressed if you have poor sleep. And what you have to do is address the sleep issue rather than the depression issue. Furthermore, if you have poor sleep, just physiologically, it predisposes you to becoming depressed. So again, that needs to be the focus. So then what's the next step? Let's say you've determined that someone is or isn't depressed. The next question is the depression there all the time? Or does it fluctuate with medications? And I tell you, I've actually had patients that have been admitted to psychiatric facilities for intractable depression and treated with every psychiatric medication on the planet, and they threw up their hands and said there's nothing we can do. And it turned out that the depression happened predictably at 6 o'clock in the morning before they took their medication, at 3 o'clock in the afternoon when the medication wore off, again at 8 o'clock in the evening. But it was such a deep depression, it was such a hopelessness that these people felt they were doomed. And then we determined, well, really there is a cycle to this, and let's improve their Parkinson's motor symptoms. Let's see what happens to the depression. And lo and behold, the depression was cured. So this is something really important to recognize. Now, let's say then that we have decided, no, it's not a fluctuating depression, so we don't necessarily treat it with dopamine replacement, but let's say it really is bona fide depression. Now, there are many medications to treat depression, but there are all kinds of subtleties to depression. Sometimes people have depression and anxiety, and then there's a certain medication. Some people have depression and problems with sleep, and then there's a different medication. It's important to work closely with a doctor that has an alliance with you, because it really is a matter of trial and error, and everybody responds a little bit differently, and you can't get discouraged if the first one doesn't work, and you try a second one. And always start low, go slow. It's a little bit of a process, but in many and most cases, it can be treated if appropriately recognized. The other big symptom that people have a problem with is constipation. And constipation may even precede physical symptoms of Parkinson's by many years. It's thought to be one of the premotor symptoms of Parkinson's. And what causes constipation in Parkinson's? Well, just like the muscles slow down, the involuntary nervous system may also slow down. And so digestion of food doesn't happen as quickly than under regular circumstances. Again, we have to differentiate between constant and fluctuating symptoms. And then it's really important to just look at other medications, because people don't recognize things that seem as benign as calcium and iron supplements. Those are terribly constipating agents. Sometimes people who have pain take all kinds of narcotics or opiates, even Tylenol #3. Those are terribly constipating. It's important to remove these from your diet. It's important to exercise and drink a lot of fluids. And in fact, diet is really, really important. And many people can manage things if they just change their diet in terms of flaxseed. And I always, every patient that comes to my office hears about flaxseed because it's very effective for my kids. Turns out it's effective for a lot of people. And if diet changes aren't enough, then there's certainly many various different agents that can help. And I have to say that I don't think I have had a case that couldn't be treated appropriately in terms of constipation. So it's not something you have to live with. Having a bowel movement once in 3 days is not something you have to live with. You can do better. So it's just a matter of working on it. So in summary, what I talked about today is that non-movement symptoms and non-movement symptoms that come and go are common and disabling. The first step is to recognize them and then determine the cause. And it's important to know that treatment is available and effective in mostly all cases, and you have to discuss this with your doctor. So before I end, I had the privilege of meeting an incredible woman this week. She joined me for one of these non-motor fluctuation assessments for my study, and she really inspired me. So I hope I can share with you the poem that she gave me, and she kindly agreed to let me read this to you because it actually brought tears to my eyes. And her name is Joan Gibbons. She's a real inspiration. I hope I can do justice to it. It's called The Perks of Parkinson's. There are two sides to everything. One is usually good, while the other has a sting. Parkinson's is no exception. It can be a mixed blessing or one of life's tougher lessons. Fortunately, life is about choices. Even when you choose to still your voice, that's a choice. You can always make a selection. Practice choosing the more positive direction. For example, you could choose to be miserable to depress. Finding something meaningful to do would be better, yes. The secret to living a happy life is to fashion it around something about which you can be positively passionate. Then you always have reason to get up each morning, always have that fresh feeling of being born again. The first 12 years of Parkinson's can be perfunctory. I look back on them as merely introductory. The first perk of Parkinson's I remember was on the occasion of beginning to take my first medication. I was always one to sleep through the night, so you can imagine my surprise as I sat bolt upright by 5 a.m. each morning while I had a day's work done before the rest of the world had even begun. The quiet of the night and early morning hours are gifts like April showers and May flowers. You need never fret about being awake when you have something in your mental oven to bake. So as the Parkinson's years roll on, one's balance goes, the legs can turn to jelly and you could go head over toes. This means, among other things, you don't do stairs well. And if you do laundry in the basement, guess what? And do tell. You can strike laundry off your to-do list and enjoy this perk. I absolutely insist. You relish the free time this gives you to do something special you would otherwise not have time to. So as you get the idea of amassing perks, you will see that life already works. Better when you openly express gratitude for the good things in life, your attitude. Changes so that when you hear your doctor say, "What is it like for you on a really bad day?" You literally draw a blank because you don't have such a picture in your memory bank. Granted, some days are better than others for sure, and that's just what's so until they find a cure. By the way, I almost forgot. Anyone can gather perks whether they have Parkinson's or not.
Unfortunately, Galit and I now have to share the mic, but don't worry, I'm just asking the question, so I won't be up here long. Okay, I'm going to ask a question that we did receive from you, and Galit will respond. Okay, first, could you please explain the recent news article about the mitochondria and the power switch in lay terms? What does it mean today for us?
I actually anticipated this question because it's such a salient and important question. And I have to tell you, I've read that study now a good 5 times, and it's still difficult to digest. And I've spoken to my colleagues about it, and I've listened to sort of all sorts of debate because it's really, really an excellent study, and I think potentially very, very important, and a paradigm shift in terms of how we perceive Parkinson's, and maybe pointing us in the direction of looking for neuroprotective agents, something that we can find to prevent the onset of the movement-related symptoms. So basically, and let's see if I can do this justice, it's thought that Parkinson's has to do with cell metabolism, and that there are, when they look at various different tissues, they find that downstream there are 5 different pathways that are affected. And they believe that in the mitochondria, a component of the cell that's involved in cell metabolism, that there is one master switch that controls all these 5 pathways. And they feel that with respect to Parkinson's disease, it might be that this master switch gets turned off. And if they can identify early who's at risk for that switch to be turned off, they can find drugs that modify the switch, that prevent it from turning off. So it's relevant in people that haven't yet developed Parkinson's. So it's something for the future. The things that have to happen, so it's not going to be tomorrow, there has to first be a biomarker. So people are working very hard in the field of Parkinson's disease to find something that is going to tell us who is going to develop Parkinson's. So there's a guy actually who I did my residency with in Boston, who's now in Ottawa, who is working very hard. His group is finding potentially that protein in the cerebrospinal fluid that may be a marker, but it's still research material, and it's still not necessarily human work. There's all sorts of animal models. So once there is that biomarker, and I believe it's going to happen fairly soon because there are so many groups around the world that are working so hard, this is key. If there's a biomarker, then the drugs can be developed to manipulate this particular master switch. And the good news is that there already are drugs on the market that are available for this. They are used to treat diabetes. The problem is that they're not right now usable for people with Parkinson's because they don't cross the blood-brain barrier, and these drugs need to get to the brain. So they'll have to be modified. So there's a lot of work for the pharmaceutical companies to do, but they're clearly motivated because whoever comes up with the medication that works is going to make a lot of money, which obviously is a good thing for pharmaceutical companies, but it's a good thing for people with Parkinson's. So that is right now sort of where things stand. There's still a lot of work to do, but at least it's the first step in finding the master switch, because up till now, much of the research has been focused on how do you replace dopamine, how do you replace this, but it's all things that are downstream rather than the one thing that affects all these downstream things. So I hope that is somewhat comprehensible.
My prescription bottle of Cinemat says, take with food. But I've heard it's best to take my medication on an empty stomach and to try to avoid taking medication with protein. Please explain.
Okay, this is one of the sort of veins of my existence, is the fact that I tell all the people that come to my office, please take your medications on an empty stomach. And what I mean by an empty stomach, no protein. And inevitably, even if I write it on the script, the pharmacist says, take with food. And so the reason, I'll tell you first, the reason not to take with food, specifically protein, you can take with food, but it's protein that is the problem, is that protein interferes in the metabolism of levodopa specifically. It's not related to the dopamine agonist, so it's not related to Requip or Mirapex. It's only related to either Prolopa or Cinnamate or levodopa-carbidopa. And that's because there is only one receptor in the stomach that takes up either the medicine or the protein to get into the blood. And when protein and the medication are in the stomach at the same time, the protein always wins. And so that particular dose is kind of wasted. It's partially metabolized, but not completely. So when people come and say, my medicine works great in the morning, but then in the afternoon it doesn't work. Well, it's not because something magical has happened in the afternoon. What's happened is that the person's had lunch, and they had a tuna sandwich, and then they take their medicine. And so that particular dose isn't that effective. And so I often counsel people to take medication either half an hour before a protein meal or 2 hours after, to try and take the protein in small increments throughout the day, and then have the big protein meal in the evening after you sort of achieved what you wanted to do during the day and been as mobile as you were going to be. And believe it or not, we go in the office through a schedule, what time you eat, what time you take your medicine, and once we do things like that, it really makes a big difference to a lot of people in terms of management of their Parkinson's. And this is part of the art, is that it's not so straightforward. Now, some people say it makes no difference, and that may be true early on, when you still have a lot of reserve of dopamine and you're not so tied to the pills. But in some people, they really require the medication, and in those people, the interaction with protein makes a big difference, and to try and avoid that interaction can really help control symptoms. And this is some of the information I'd like to impart in our webinar, because it seems like something relatively simple, but if somebody doesn't tell you that, and the bottle says take with food, how are you supposed to know that you're not supposed to take with food?
What is the difference between cognitive decline and dementia? What percentage of people with Parkinson's develop dementia? And how do you tell the difference? My doctor doesn't like to talk about these things.
Well, cognitive decline, these are sort of semantics. Cognitive decline implies that there's been a change in thinking. Dementia is kind of I hate that term, but it's a clinical diagnosis that implies that the cognitive decline is enough to impair one's ability to do their activities of daily living from a cognitive perspective, that it interferes in their life and in their function. So that is maybe the term. Some people use them interchangeably. When you say cognitive decline, you're implying that somebody has an impairment in their thinking. By definition, dementia means it has to be severe enough that it's actually interfering in your life and you can't really function without assistance. In terms of how many people develop dementia, that's a really tough question. There's a spectrum. I think that, without getting too technical, there's a protein in the brain called the Lewy body, and that is the sort of hallmark of Parkinson's disease. And nobody knows if it's actually causing damage in and of itself or it's a byproduct of some other metabolic process and it's just a marker that there's Parkinson's disease. But that is how you define Parkinson's if you were to look at a brain specimen. So to sort of simplify, people think that if you have some of these Lewy bodies in the cortex, in the thinking parts of the brain, then that can cause cognitive impairment. And oftentimes, the longer you have Parkinson's, the more likely it is for you to, over time, develop those Lewy bodies in the cortex. Not everybody develops dementia. A lot of people have cognitive impairment, which means that they have some changes in their thinking, but it doesn't necessarily get to a stage where they are so impaired that they need assistance. I think it's something extremely important to talk to your doctor about. I actually have a colleague by the name of Mary Macelis, and he is a behavioral neurologist at Sunnybrook Hospital. He's absolutely terrific, and his specialty is looking at the thinking problems related to Parkinson's disease, and we work very closely together. And his research interest is actually finding a medicine that's specific to each individual. It's sort of a little bit far away in terms of right today, but he's looking at pharmacogenomics, meaning that looking at someone's particular genetic profile to determine which one of these agents are going to work better for them than others. Because right now it's, again, a little bit of trial and error. So there are some medications to enhance thinking. For some work better than others, some work better than others in certain people. It is something important to acknowledge, but not to live in fear of necessarily. Sometimes you do have to plan that that's a possibility in the future. You may have to modify some of the things that you do, but it doesn't change the fact that you are still who you are, and you still have to enjoy life. And as we talked about in our focus group this week, that life goes on, and you live, and you continue to live, no matter what happens.
That's a segue to another question that we had, and that is that how would a doctor know whether you have Parkinson's disease or Lewy body dementia? I understand that Lewy body dementia starts out looking like Parkinson's disease, but that's the question basically. How do you know?
Excellent question. I don't know, and neither does anybody, because it's a pathological diagnosis. And what people are, so even Parkinson's is a pathologic diagnosis. So when you're alive, you can only say that someone either has possible or probable Parkinson's. Confirmed Parkinson's doesn't happen unless one looks at the brain under the microscope. So one of the reasons that it's sometimes difficult to diagnose Parkinson's disease or differentiate it from other Parkinsonisms is because there's no lab test and there's no proof. It's based on the experience of the doctor that is evaluating you. And hopefully, if they are movement disorder physicians, all they do all day long is see people with Parkinson's disease and they look for things that are typical versus atypical. And it's a clinical diagnosis. So somebody who has sort of slow onset, insidious onset of resting tremor, that then may have reduced arm swing, that then may get a little depressed, but then they take levodopa and wham, their symptoms are all better. That's pretty typical for Parkinson's disease. So I don't know for sure 100%, but I know all the other possibilities that it could be, and it doesn't really fit into any of those other possibilities. Although I never like to make a diagnosis the first time I see someone. I like to leave it open and see how they evolve, if they evolve. Sometimes people don't evolve. Sometimes it's important to also determine if they respond to medication or they don't respond to medication. That's helpful in diagnosis. Because people with Parkinson's disease respond very nicely to medication, as opposed to people that have Parkinsonism, which is kind of a generic term, talking about the signs and symptoms if you see Parkinson's disease, but don't necessarily have Parkinson's disease, we have mimickers. And when I mean Parkinson's disease, I mean having those Lewy bodies in the brain, because that is specific to Parkinson's. Those other forms of Parkinsonism don't necessarily have Lewy bodies in the brain, but we don't know. So now the reason, in terms of the Lewy body dementia and what we call PDD, Parkinson's disease dementia, so we have cognitive impairment as a result of Parkinson's disease, how are these differentiated? It's very difficult, and now people are beginning to think that this is actually just a spectrum, that it's just a matter of how much Lewy bodies and where they are. So if you have those Lewy bodies up front first in the cortex, it presents as Lewy body dementia. And there are some things that are associated with this. Oftentimes there are fluctuations during the day, wide fluctuations in cognition, where 1 minute you are pretty good and the next minute you're pretty confused, and hallucinations are really important to that as well. There may be a significant reduction in blood pressure, and there's usually not that much response to medication, often because the movement symptoms aren't really that bad. It's more the cognitive and hallucinations that are the issue. So again, the differentiation is clinical, it's somewhat semantic, but it's important to know, because if you go and give people with upfront Lewy body dementia medications to treat Parkinson's, it can actually make that hallucinations much worse. So we have to be very careful.
How successful are implantations of stem cells for Parkinson's disease?
Well, I think people used to be pretty excited about this as the future of Parkinson's, but I think research has borne out that it's not very effective. There are a lot of risks. There was something called runaway dyskinesias, where they implanted these stem cells in the brain, and there were connections that were formed, but not exactly the right places, and so people started to have these involuntary movements that were very difficult to treat. I think there's still some groups around the world that are hoping that stem cells will be the answer, but I think on the whole, it's not necessarily going to be the cure. I think that probably genes are really where it's at, and trying to implant, again, the problem is with respect to dopamine. The stem cells are really to address the dopamine issue, but as we talked about, Parkinson's is a lot more than dopamine. So even if they were to get it right with regards to the dopamine, it wouldn't address any of these other problems. It doesn't necessarily address the progressive nature of the illness. I think if you're talking about surgery, there is an effective surgery. There's deep brain stimulation. Deep brain stimulation also mostly affects dopamine regulation, but it's very effective for this, and it's very good in terms of reducing these ups and downs. And in people that have side effects from medications, you can often reduce the medications to a significant proportion such that you don't have those side effects. But it's not the answer. It's also it's a symptomatic treatment, but it's a good one in the right person.
Is it common for people with Parkinson's to lose weight? And what can we do about that?
Yeah, of course. There are many, again, you have to tease out what is the cause of the weight loss. First of all, anyone can lose weight. Not everything is Parkinson's disease. It's really because I actually have had the other end of the spectrum where people come to me with every possible problem and they relate it to Parkinson's. I say, yeah, you have Parkinson's, but it's fair game, anything else as well. So not everything is Parkinson's disease. But it is possible to lose weight as a result of the Parkinson's. There are various different reasons. And have to tease these out. One, is the person depressed and not wanting to eat? Two, is it because somebody is nauseated so they don't have an appetite? And that may be a function of side effects of medication. Three, is it because they've got so many involuntary movements that they're burning things up? And so they're just metabolizing much more quickly, so they're exercising constantly. So yes, you can lose weight. And in fact, a lot of research has been shown that when people have deep brain stimulation and they no longer have these dyskinesias, they gain weight. Other possibilities is somebody has problems swallowing, so they're not eating as much because of that, or also just in general, they're slowed down so much that they eat so much slower, and they're chewing slowly, and they get fuller sooner. So there are many reasons for losing weight in Parkinson's, but as I've outlined, these can all be addressed if it's recognized what the causes are.
What's the difference between dyskinesia and dystonia? And what's Botox, and does it help?
Well, dyskinesia is just a generic term to mean involuntary movements. And dystonia can be a dyskinesia, but dystonia is very specific. It refers to an involuntary posture that's often twisting, can be painful, in the context of Parkinson's disease, you can get dystonia, especially what we call early morning dystonia. So first thing in the morning, if somebody hasn't had medication all night long, and they wake up in the morning before their medication, they may have a cramp in their calf, or their toe may either stick straight up or curl under, and this is dystonia in the context of Parkinson's. Now, dystonia is a completely separate entity. It's another movement disorder that has nothing to do with Parkinson's disease at all, but you can get dystonia in Parkinson's disease. Oh, Botox, right. Sorry, my 4 a.m. start this morning. Botox is the other hat I wear, so I actually do a lot of treatment with botulinum toxin. I'm not going to say Botox because that specifies which drug company. Botulinum toxin is actually it is a toxin that's made by a bacteria called Clostridium botulinum, and it can kill people. Actually, probably you've all heard of botulism, where kids who eat honey can then become paralyzed and die. But botulinum toxin has been found to have some specific uses, especially in people that have excess involuntary tone. So sometimes people that have strokes, they've got what's called spasticity, and they have increased tone. But dystonia is also a form of increased tone, and botulinum toxin is very good to be used in small doses in selective muscles to reduce that inappropriate increased tone. So we have to be able to determine which muscles are being affected, and oftentimes instead of cranking up, in Parkinson's, instead of cranking up medications and that can cause all sorts of side effects, if we just do a localized injection of botulinum toxin into the muscle affected, we can significantly reduce that discomfort. You have to know which muscle is affected, and I use an EMG machine, which is a muscle stimulator to tell me that I have the right muscle and to prove to me that in fact it is increased in activity. And then I inject the medication, and after about 3 months it wears off and it needs to be done again. There are now, it's a very expensive medication, but there now is an LU code, limited use code by the Ontario government, so it's on formulary, so most people have access to this now. But it's a very effective treatment for a localized increased tone like dystonia.
I was diagnosed at 61. And my father-in-law was diagnosed at 75 years of age. Does genetics increase the risk for a Parkinson's diagnosis for my children?
This is a really excellent question, and very hard to answer. We are finding more and more that there are genetic susceptibilities to Parkinson's disease, but nobody thinks that it's just the one-hit hypothesis. If you have that gene, you're going to get Parkinson's. It's thought that there's a complex interaction between gene and environment, so that maybe you have a genetic predisposition, but there have to be other events that happen as well, multiple hit hypothesis, in order to develop Parkinson's. So just because you have Parkinson's doesn't mean your kids will have Parkinson's. Now, it's not uncommon for us to see somebody who had Parkinson's disease say to us, oh, but my grandfather had Parkinson's. Clearly there's a genetic component. And there is now one particular gene that has been determined to be probably the most common gene to cause increased risk of Parkinson's disease. It's called the glucocerebrosidase gene. And when you have 2 copies of this gene, you get a disease called Gaucher disease. And Gaucher disease has nothing to do with Parkinson's disease. It is a blood disorder, and it causes increased size of the liver and spleen, and it can affect bones. But it's been found that if you carry one of these mutations, so it means that you don't have any disease, but you are a silent carrier, you have something like a 12-fold increased risk of developing Parkinson's disease. And there are certain ethnic communities that are more at risk for this particular gene than others. So people, and this is one of actually my interests as well, is doing sort of population studies, and we're working with people at the NIH and around the world to start to monitor people for this particular gene. There are other genes, something called MARC2, DJ1, there's a whole slew of genes, but these are all much rarer. And you have to have 2 hits of them in order to actually develop the disease. So just because you have Parkinson's doesn't have necessarily any implications on your family. And just because your parent had Parkinson's doesn't mean that you're going to develop Parkinson's.
Question is, are there any prospects for a longer lasting medication? And I think we get a lot of questions about what's in the Parkinson's pipeline regarding medication in general. What kind of hopeful things are out there as far as medication is concerned?
Well, there have been a lot of sort of encouraging things and then disappointing. I think clearly everybody recognizes the fact that the short-acting levodopa, while it works, it's great, but it doesn't last long enough. So there's sort of this hit and then wear off. It's kind of like hitting the receptors, but overshooting and then wearing off, and it's up and down. So in theory, if you could get a medication that could sit on the receptors and stay there for a prolonged period of time, there'd be a smoothing out of effect. So that's when they developed CR, and that had great potential, but unfortunately, CR meaning controlled release, it didn't work that way. It just was unpredictable in terms of its metabolism. So people didn't get the full effect of the levodopa, but they did get the side effects. So that wasn't such a great option. In terms of more long-acting medications, some of the strategies to use the dopamine agonists like Requip and Mirapex, because they aren't this sort of hit the receptor and come down. They work in a different way than levodopa, and they stay on the receptors the whole time. And so yes, they are more smooth in that regard. potentially increased daytime sleepiness, a lot of nausea related to food. So you can see that in theory it's a good thing, but in practice, probably many of you have experienced that these medications aren't as great as they should be. What we're trying to do is combine the two, using them both in low doses to avoid the side effect profile and to try and balance out that hit with the levodopa, which is a strong effect, with the smoothness of the dopamine agonist. I think in Europe, and I think that they're trying to do this in Canada, but it hasn't been approved yet, is something called Duodopa, which is a pump that is inserted directly into the small bowel, and it allows for that, with some people as Parkinson's advances, the medication becomes unreliable, so they say, well, my medicine doesn't work anymore. It's not that it doesn't work anymore, it's that the absorption of it is unreliable in the GI tract. So if you can bypass the stomach and go directly to the intestine, it's a much more smooth effect. And it's been working pretty well in Europe, but there's been some regulatory problems getting into Canada and the US, so it's not here yet. There are all sorts of things in the pipelines, but and all sorts of, you have to be able to differentiate between the marketing and the actual effectiveness. So we always get enthusiastic to begin with and get a little disappointed so far. I'm hoping that there will be, as I said, there is an incredible amount of research and research support from sort of the American government and Europe and Canadian government as well in order to look for new products to help people with Parkinson's. But amazingly, still the mainstay of treatment is the treatment that was first developed, which in the 1960s is levodopa.
How do things like Mercurians, herbal supplements, etc., testosterone, DHEA, how do they affect levodopa?
Okay, I have to admit here, oh dear, I don't know. There's certainly not, it's not standard therapy out there. All I can say is that there are some things that actually affect the metabolism of the levodopa, so one has to be very careful when taking supplements. This stuff is not, there's no studies per se to justify the use of it. When people come to me with using various different natural products, I say, well, as long as it doesn't hurt you, it's fine with me. And there's no evidence that suggests that it hurts, then it's okay. And I don't know. I mean, I remain open. It's possible that these things are effective, but there's no data to support it.
My biggest problem is poor balance, and that's why I keep falling. I fall at least once a week. Is there something about my falling? Can I do something about my falling? I also have problems with my speech. My handwriting is as good as 0. Please help. Okay, would you say something?
Well, again, going back to the point that the management of Parkinson's is often more art than science, and that's I wouldn't be able to really address this issue unless I examine the person myself and look at their medication regimen and determine if their falls happen when they're off and if it's a predictable sort of timing, because this is very typical symptoms of when people's medication is worn off. That being said, oftentimes even under the most optimized situation, balance can really be impaired, even when you take medications the right way. And that's again going back to the point that not everything is dopamine. So in addition to the fact that some non-movement symptoms are not related to dopamine, there are also movement symptoms that aren't related to dopamine. And generally the midline, the axial things like swallowing, voice, balance, midline stuff, often at some point may not be necessarily responsible for dopamine replacement. My first step is always to optimize medication. I also have to recognize when somebody's at risk for falling and admit that that is a problem and that I may not be able to fix. But at that point, I try and do damage control because once the broken hip happens, too late. So we want to avoid that. So we have to sometimes be extremely cautious. I don't know if many or all or some of you are familiar with the program that Rebecca Brewer and Jan Goldstein run. It's an incredible incredible exercise program for people with Parkinson's disease. And just like there are general neurologists that don't know that much about Parkinson's, there's also general physical therapists that don't necessarily know so much about Parkinson's. So it's really excellent to have therapists that are able to recognize the problems that people with Parkinson's have and address a therapy regimen that is particular to Parkinson's. And they're ones that had mobility, and they're terrific. So we sort of approach it in a multimodal fashion. We optimize medication. We try and get them into a very good therapy program. Also learn strategies as to how to prevent a fall, because people with Parkinson's may have reduced postural reflexes. That means that they don't have that gut reflex to be able to put their hands out when they fall. They just fall backwards like tree stumps. And so they can really injure themselves. Therapy, exercise, medication. At some point, we suggest certain mobility aids. And if walking is just too dangerous, sometimes alternate measures of mobility have to be used. Scooters. Not to say that people shouldn't walk, but they may need to walk with supervision. Walking is extremely important, if possible, to maintain mobility and to maintain flexibility, but it has to be done in the most cautious and safe way possible.
How do I control my constant fatigue during the day and my inconsistent sleep of not more than 2 hours at a time at night?
So as you can see, many people are asking these same questions that I sort of addressed in the talk. Sleep is a really big problem, but there are many different causes to sleep problems. So now, is this person taking Mirapex and it's causing them to be extremely tired? It may also alter their sleep-wake cycles, so that part of the night they're not sleeping because they're sleeping all day long. They may have what's called REM behavior disorder, which is something that commonly happens in Parkinson's disease, and that is the acting out of dreams, the sort of intrusion of wakefulness into sleep. And so they're not getting restful night's sleep. Sometimes they're depressed, or they're having all sorts of ruminations in the night, and that's keeping them awake. So there's a sort of standard approach to sorting out what the cause of the sleeping problem is and ways to address it. If I can't figure it out after a few times and the methods that of intervention that I try, I again send people that have intractable sleep problems to my colleague, Dr. Brian Murray at Sunnybrook, and he's another person that I did my training with in Boston, and he's turned out to be a world expert in the sleep problems related to Parkinson's disease. I have yet to see somebody who hasn't been able to help. So we try and figure out what the problem is, address it to the best of my abilities, and then move on to an expert if necessary.
Is there any research going on regarding the ability to measure dopamine levels?
Yes, but I don't know that it's really that relevant. So we are able to measure dopamine level. All we have to do is take a blood test. But as I said, dopamine isn't really the big issue. The big issue is what's causing the degeneration in the first place. Dopamine replacement is possible. We do it pretty good. So I don't know that that's really that salient question. I mean, it's an important question, but yes, we can do it. It doesn't help us solve the problem.
This question actually talks more about exercise. It specifically asks about dancing, Tai Chi to improve balance with Parkinson's, and also does massage therapy make a difference?
I am a very strong proponent of exercise for anyone, but especially for people with Parkinson's disease. It's incredibly important for both body and soul. There's been now a lot of studies that have done and shown benefit for people that exercise continuously with their Parkinson's compared to those that don't exercise. I actually have one gentleman that I care for. He's had Parkinson's for 20 years. He's actually a physician, and he is a real diehard yoga fan, and it's amazing what yoga has done for him. He is still practicing. lot of work going on looking at that as to what is it about music and dancing and rhythm that helps people overcome mobility issues. But so yes, I can't tell you technically exactly why, but I think that anecdotally, certainly I've seen an awful lot of people benefit from dancing and exercise. Now, in terms of massage, well, it sure feels good, so it can hurt, and it's good to stretch muscles, and it's sort of part of an overall comprehensive program of living well.
This isn't gender specific, although it does talk about a wife, but I think it could apply to some husbands too. What makes him or her sit all day? He, she doesn't want to go outside or go for rides. Also, how can I encourage him or her to walk faster and take longer strides? Marital therapy is down the hall.
Well, this is, there's some humor to this, but there's also, I mean, a lot of truth to this. And I can't tell you how many times I hear this in my office. My husband or wife used to be this vibrant person. Why don't they want to do anything anymore? Yeah, they have Parkinson's, but it doesn't mean they can't enjoy some things. And this comes back to this issue of apathy, which can really be a problem. I have to be honest, we don't have such good drugs for apathy. And what I tell people is you have to, if that's the case, even if you don't feel like it, there has to be a structure to your day. You have to have things planned, and you have to do them. You just have to, because you can't sit and look at the wall all day long. And when people have it's a really important thing to have social programs. I mean, not everybody is, I'm going to a group kind of person, but every person has things that they enjoy, and so this has to be scheduled for them, and they have to show up. Now, again, there has to be optimization of medication, because oftentimes when you optimize the dopamine balance, you can also improve some of these other non-motor features as well. So, and when apathy is really difficult, again, I have a colleague at Toronto Western, Dr. Zarowski, which you guys may know. He's fairly specialized in being a neuropsychiatrist, specifically interested in movement disorders, in the cognitive and mood issues related to movement disorders. And he's also been helpful to people in terms of apathy. Now, I had a gentleman just last week that I've been seeing for 4 years, and his movement-related symptoms are really pretty minimal, but his family comes in en masse. There's 4 of them, all the kids and the wife, everybody comes, and they say, we tried to take him all the way, we tried to do this, we tried to do that. He doesn't want to do anything. What can we do? And we've tried all kinds of different things. And when you question him, you direct know, what do you feel? Why? It just doesn't feel like it. But he's had a lot of sleep problems. And so when we helped him with his sleep, and he got a good night's sleep, he actually came in for the first time in 4 years, ran into the room, told me how they were going on vacation, had a smile for the first time that I've ever seen. So it can be done. You just have to identify what the issues are. In terms of the stride length and the walking, I think that, again, if you can optimize medication, work with your doctor to get it right, those are the kind of things which should improve with medication replacement.
Okay, so we've come to the end of our questions at this point. We are about 5 minutes ahead of schedule, which is unheard of. But that's not a bad thing, it just means I didn't talk too much. At this time, I would like to thank you so much on behalf of every one of us in this room. You can tell when a speaker is making a difference and when people are engaged. Quite often, when I'm in front of the group, I see a lot of boring. Okay. Obviously, I don't see any nods. I don't see one. I see eyes alert and awake, etc., etc. So I think that shows you that this presentation has indeed been very, very, very impactful and helpful for people living with Parkinson's and their care partners. And just like I said, I don't think I sold you a bill of goods. This is who she is all the time. This is not just Dr. Kleiner Fisman this morning. You guys put on a presentation. I've had the privilege of sitting in with Galit on patient interviews and assessments. She is who she is. She's just this very warm, generous, lovely human being that we're very blessed to have as one of our wonderful movement disorder specialists. Please give her a very warm thank you.